isn't thinking properly, okay? So in Parkinson's, this can occur at any point related to the dopamine, or it can occur later on, kind of associated with dementia. But it's not always associated with dementia. Sometimes it can be earlier. And it can really reduce the quality of life. And it can happen to small degrees or large degrees. Psychosis includes hallucinations, delusions, and paranoia. Hallucinations would be like if I see that there's two kids standing on the corner of the stage, but nobody else can see them, my brain is telling me that those two kids are there and they're watching me. They may or may not talk to me, but they're there. So in my brain, it's real. You can't logically say, no, they're not there. See, I can't touch them, can't talk to them. It's just the brain is misreading its information and inventing those two kids there. So that's something that part of how you deal with it is just how you react to it. You know, the fact that you can understand that that person is really seeing it. And so, I don't know, it can be hard for families to deal with. Delusions is when you have a false belief. Like, I think my husband's trying to harm me. Or I think my wife is trying to steal all my money. Things like that. That's a good one. So, those are delusions. And that kind of falls over into paranoia too. Delusions are just any false belief. It doesn't have to be fear related. But paranoia is just fear to the nth degree, way out of control. Oftentimes, they just start out in the sundowning hours. If you've heard of Sundowner Syndrome, that's specifically pretty much related to dementia people, that about 4 or 5 o'clock when the sun goes down, they start getting all this stuff. And as soon as the sun comes up the next morning, they're back to themselves. So initially it's mainly those time periods, but later on it can be any time of the day. Treatment. The first thing is making sure that there's nothing else going on, because usually, especially for first episode, usually you'll find something else going on that set it off. Either a new medication, somebody's got an illness, they got a urinary tract infection that they don't know about because they don't have symptoms. It could be dehydration, electrolytes getting out of balance. All those things can just take a person that's functioning well, and one day, all of a sudden, they're confused, they're hallucinating for the first time ever, they're not acting themselves. That could be why. First thing is to simplify the medication list. Get rid of any medications that they don't need. Doctors can be bad about starting things and never looking at it again. They think you're going to take it for the rest of your life, but sometimes you don't need to. You need to get rid of some of those medications that are causing problems. For Parkinson's, there are several medications that can exacerbate these issues. So we will simplify, get rid of those, and kind of go back just to levodopa, or as few things as we can. In some cases, even the levodopa is contributing, so we got to decrease that. There are times when we will actually add an antipsychotic, and until a few months ago, all we had were 2 antipsychotics that have been around a long time, but neither one was a great option. One of them, this one, clozapine, required frequent drug tests, like once a week for 6 months, and then every second week, because it can lower your white blood cells. So that's a big side effect. So nobody wants to do that straight out of the gate. So the other one is quetiapine. And that one is much safer, so it's much easier to use, but it's not as strong or effective as the clozapine. So you kind of dealt with, okay, do I want to deal with this one where I have to get a lab test, it's got the serious side effect, or just use what I can get away with? However, a couple months ago, not even, there's a new drug on the market that can help with the hallucinations, and it's called PMDAlliance. So it's especially helpful if you're just now getting hallucinations, delusions, and starting a medication. When you're already on one of these other medicines, it's harder, it's still possible, but it's harder to try and get down off the old one and get onto the new one and have it take effect, without having a little mess up in the middle. So. Okay, last thing we're going to talk about is the cognitive stuff, cognitive decline. This is a slide that just shows different symptoms of the Parkinson's disease. It starts with preclinical. That means symptoms that are started well before you know you've got the Parkinson's. Things like the sleep changes, the constipation. Once you get diagnosed, your first several years are considered a honeymoon. You can miss a dose of medications, you can be late with a dose, no big whoopee. Nobody notices and everything's fine. But later on, when your brain makes even less and less dopamine, remember all of us are losing that dopamine, at some point you start relying on those pills more and more to get your dopamine every day because your brain is making less and less. And at that point you start having wearing off where the medication doesn't last from dose, the first dose to the second dose, or dyskinesias, which is like extra fidgety movements. When the dose gets in your system and works, dyskinesias is when it works almost too good and it gives you movements that you don't want. Later on, about 15 to 20 years out, is usually where cognitive decline starts. Sometimes it starts very early, and in that case, oftentimes, if it starts early enough, we'll call it something different. We'll call it Lewy body dementia. But usually it starts out here 15, 20 years down the road. So, some earlier problems include these. Difficulty paying attention, especially on a complex task. Difficulty thinking of the words you want, or forgetting your whole train of thought. Having problem-solving trouble, where you can't figure something out like you used to be able to figure it out. Mental processing is slower, so when somebody asks you a question, there's more of a delay while you think about it, and speech may actually be slower because it's harder for you to process everything. And then visual spatial is the last one. Visual spatial is, I think of it as particularly important to things like driving, where you're trying to determine, how fast is this person coming and how much time do I need to get there and things like that. Later on, cognitive decline can also include confusion, along with hallucinations and delusions, just like in psychosis, and then also agitation or behavioral problems. So, one slide. This agitation and behavioral problems is actually something that one of the cognitive, or a couple of the cognitive medications can help with. And so, actually, I'll talk about that again in a minute on the next slide, I think. No, let me talk about it right now before we see it. So, there are some memory medications that help keep our memory on the stable, keep it from declining further, but they also help with behavioral issues, that agitation and such. And so if somebody says, well, his memory's shot, just stop the medication, why do you need that anymore? The memory's gone. And they stop the medication, sometimes those behavioral things come out tenfold. And then you're like, you wish you'd never stopped the medicine. So this is a little diagram that shows normal aging. Normal aging is the green lines. And this is time from birth to death. So over our lives, we all have some decline in our cognitive status. Usually it's things similar to some of the Parkinson's things. Slowing down of thinking, forgetting the words you want, difficulty paying attention. Those are common with aging. But at some point, people get a little bit more than what they expect as far as those symptoms. And at some point, it even can further deviate from that line and start going downhill much faster than your peers or your other people your age. So at that point is when we start looking at it and saying, oh, maybe we need to treat this. If it's just a milder thing, this is it anyway. If it's a milder thing, we call it mild cognitive impairment. That was at that first part of that curve. If it's a bigger problem that actually affects two or more areas of thinking function, and it affects your ability to do your daily life activities, that's when we call it dementia. So really the difference is just in severity. Dementia one big issue is that it's not the same as dementia of Alzheimer's dementia. Dementia is this huge category, like facial tissues. And yeah, Kleenex is most of the facial tissues out there, but there's other facial tissues. Well, dementia is just a broad category. Alzheimer's dementia is the biggest part of that category. Parkinson's dementia is different, very different. Once somebody has had Parkinson's about 15 to 20 years, so this isn't at the beginning, this is at the end, down the road, then there might be 20 to 40% of people that would be categorized as dementia. And again, it's a spectrum, so some are better, some are worse. For the cognitive impairment, at the time of diagnosis, it can be about a third or a quarter of people have what we consider mild cognitive impairment at the time of diagnosis. But that increases too. By 15 to 20 years out, that's a majority, 4 out of 5 people. But again, you guys think, well, how many of my peers also have cognitive impairment? So, treatment. There's a saying from the Green Valley Parkinson's Support Group that I really like and I use a lot. It's called Give Parkinson's the SAC, S-A-C. Stands for mentally stimulated, doing things like online lumosity, playing bridge with your friends, whatever, reading books, learning something new. Next one, sewing works, okay. Physically active and socially connected. So all those things are important to keep our brains healthy. It helps prevent dementia, it helps keep our brains and our bodies working as they're supposed to. A nutritious diet and adequate sleep. Those are just common sense things. Anybody that doesn't get a good night's sleep, they're not going to function as well the next day. And dietary-wise, it's just kind of common sense things there too. Getting enough water, enough fruits and vegetables, fiber, anything that you would consider healthy for your heart and everything else. Again, with the medications, first thing, get rid of things you don't need. Get rid of things that are contributing to this problem. And after that, then start saying, okay, these are the medications that might help. What these medications are doing, we're hoping, is that when you're on this downward cognitive decline, they're supposed to help stabilize you out. They don't get you back to normal or even back to a younger age. They just help stabilize that decline and try and keep it level. But they have a good effect on behavioral symptoms that often go with dementia. And that can be agitation or aggression, or especially during those sundowning hours, 4 o'clock on. Rasagiline is basically just a generic name for Azilect. There's been some studies that suggest maybe it's helping with cognitive, but not enough to be certain. And it's certainly not anything that can replace like the Aricept or Exelon. So another way to think of cognitive treatment, there's 3 parts to your memory. You have to get the information in, which means you have to pay attention, listen, get the information in there. Then you have to store it, and then when you want it, you have to retrieve it. If you're not doing a good job of getting the information in there, you're not going to remember it. So things like paying attention, just do one thing at a time. Don't try and do 10 things while you're listening to somebody else tell you a direction. Repeat what's said to you, visualize it, associate with other things, and then organize. Use a lot of lists. Use a calendar, a central calendar in the main room. Write things down. All those things can help you to lay those memories down such that you can recall them better. And then the final thing, again, is exercise. They actually did a study way back. I don't have all the details on this, but they did a study looking at people's memory before and after so many weeks of exercise. One group, they divided people into a group that actually did nothing and just sat around, did their own normal daily living stuff. One group walked 1 block every day. One group walked 2 blocks every day. One group walked 3 blocks every day, all the way up to 25 blocks a day. That's 2.5 miles a day. And when they tested memory at the beginning, they kept track of it. They tested memory at the end. And would you know that the people that walked more, it was a direct correlation. The more you walked, the better your memory was. It was a direct correlation. So a simple thing like just going out and walking in the neighborhood can be beneficial. So exercise, I think. Yeah, that's all. Okay, any questions about anything? Yeah.
When you talk about reducing or simplifying the medication, do you mean under a doctor's supervision or?
So the question is, when I talk about simplifying the medication list, what do I mean? Just stop things on your own or do it under a doctor's advisement? There are certain medications that will be contributing to these problems and others that won't. There are certain medications that you really need to stay on and others that you don't. So yeah, definitely do this under a doctor's supervision and together decide what are the pros and cons of each medication. You might go in there with a question, hey, do I really need this one? Can I get rid of that? And then they'll have to help you decide what are the pros and cons. Is that one you can get rid of or not? Other questions? Yeah.
Is vertigo also a part of Parkinson's?
So the question is vertigo part of Parkinson's? And no, it's not. It's another thing that affects our balance. Vertigo is caused by problems in the inner ears. And if they're not working, usually it sets up some kind of a sensation of a dizzy, like a spinning sensation. And that gets you off balance. And so it affects balance. Parkinson's affects balance. But Parkinson's doesn't contribute to the vertigo at all. Other questions? Yes?
Is there a certain length of time you need to walk? So the correlation.
Good question. So the question is there a certain length of time you need to walk? Along with that, people often ask, what's the best exercise? So for that, the simplest answer is the best exercise is the one you'll do because you like it. If you're trying to force yourself to do something you don't like every day, you're not going to drag yourself out of bed to do it. As far as time frame, there's been different recommendations over the years. I think the more recent one is probably 30 minutes of good exercise every day for 5 days a week. But partly it's just where are you at and where are you trying to get to. If you're not very active right now and you're trying to get going, you want to start small and work your way up. You don't want to work out so hard one day that it takes you 3 days to recover. That's too much, that's too hard. And you won't be able to maintain it. So just little by little, work up, work up. Often it's good to use a physical therapist or a trainer to get you started, to know how to do exercises properly. And then you can learn those exercises, jot them down, and keep doing them on your own. In general, getting a good balance of different kinds of exercise is helpful. Anything that uses weights or rubber bands, usually you think of that being good for strength, right? You do those machines or the little dumbbells or things. So yes, that does help the muscles strengthen, but also that helps the bones to keep stronger, so that if you fall, you don't break a bone. Things that are like a stationary bicycle or treadmill, if you can do it safely, or just walking, those are things that if you're doing it enough to kind of breathe a little bit heavier, it's like hard to keep a conversation and breathe at the same time. That's what we call cardio exercise. It's good for your heart. It's also good for your memory, keeping the blood supply to the brain good. So it's good. And then there's other exercises too. So we got strength, we got the cardio. We've also got balance exercises. Just doing things daily. You can stand next to a counter where you can hold on if you need to. Practice standing with one foot in front of the other and see if you can let go for 30 seconds. Try it with the other side. Try standing on one foot. Try standing on the other foot. Different things. There's all kinds of different exercises. And I think, did you already talk about the exercise thing online?
Nope, we're going to next.
Okay, so you're going to find one source of a way to get exercises to do later on. The last kind of movement exercise is stretching. And I'm notoriously bad about this. If we don't do things that stretch, we won't be flexible anymore. And we need to be flexible so we can bend over and get our socks and shoes on and get our pants on and things like that. So Stretching is another good one. You can even do it just laying in bed. One of them is just try and reach your toes when you're laying in bed, you know. So
That's
Okay.
good, thank you. Any other questions?
I didn't hear anything mentioned about supplements or.
Oh,
So the question about supplements, vitamins and things like that. There have been some specific supplements like CoQ10 and creatine, and a few others that have been studied over the years, thinking that perhaps they could slow the progression of Parkinson's. So far, none of them has been able to slow the progression, but they do benefit in other ways. So those are things you can take. A lot of people with Parkinson's would be on the CoQ10 or creatine or something like that. Oftentimes people with Parkinson's are low in vitamin D, and so often now the primary care doctors are checking vitamin D levels in people, and if you're low, you can just take that over the counter. Magnesium is a supplement that's really good for constipation, leg cramps, and sleep.